Okay, Chapter 22. Chapter 22 is over allergic reactions. Allergic reactions really not something that we deal with on a regular basis. In fact, most allergic reactions we don't even really see in EMS. People have a type of an allergic reaction and never really becomes even anything that they see their doctor about in many cases. When we do see allergic reactions, we typically see the worst form of those, which are referred to as anaphylaxis. Occasionally we do have somebody who calls for an allergic reaction. They get a little upset and freak out a little bit. So our objectives, as found on your page 530 in your textbook, just a few of them there here for the allergic and anaphylactic reactions. We will talk a little bit about another medication in this chapter called epinephrine. Epinephrine gets used in cases of severe allergic reaction or anaphylaxis to help buy the patient a little bit more time. A couple multimedia slides regarding allergic reactions and allergic rhinitis. Many of us probably suffer from allergic rhinitis, and that's really kind of the medical term for the common hay fever. So our core concepts that we'll talk about will be identifying the patient experiencing an allergic reaction, comparing and contrasting the mild allergic reaction to a patient in anaphylaxis, how to treat a patient experiencing an allergic reaction and anaphylaxis, and then who should be assisted with an epinephrine auto-injector. So allergic reactions. An allergic reaction is the immune system naturally responding to a foreign substance in the body. When we have an allergic reaction, it's an exaggerated response to a foreign substance, and the allergen is that substance that causes that exaggerated effect. So anytime we get something that doesn't belong in our body in there, the body has some sort of a reaction to it. And in most cases, it might be a few white blood cells here or there to try to kill off this organism, but the body generally does it almost seamlessly, and in many cases you don't even realize that it's even done anything. In the allergic reaction person or patient, the body's kind of gone haywire and gone into overdrive and says, oh, this is especially bad, we need to get this out of here. And so the body comes under fire pretty quickly. Now, with that being said, nobody is allergic to anything the first time they come into contact with it. The first time you come into contact with it may be the time that you become sensitized. And sensitized means that the body has built up certain antibodies to attack this, what is actually called an antigen, or in this case would be allergen, to attack it and start to destroy it. If you've never been exposed to it before, your body is going to identify it and make steps to combat it the next time it comes into contact with it. Now, it is not always the second time that a person comes into contact with a certain allergen that they start to sensitize, and sometimes they've come into contact with something for years and years and years, or even decades, before their body all of a sudden just flips a switch and says, oh no, this is a bad thing, we don't want this anymore. So you have to have the sensitization period. So that first exposure, that's when that body's immune system starts to form antibodies, and those antibodies identify and attack that particular foreign substance. Then antibodies combine only with an allergen that they were formed in response to. With that being said, some substances are very similar, and because there's a certain protein or something in the basis of that substance, it may actually be that protein, the individual protein, that the body has built up a reaction to, as opposed to the substance itself. Say, for example, people that are allergic to latex are often also allergic to bananas because they're a very similar plant, so there's a similar protein in there. So things like that you will see happen in related fruits or other substances, that they start to build up some additional allergies to related substances. So on second or subsequent exposures, and I don't want you to believe that it's always the second, while that antibody exists and the antibody combines with the allergen, and it leads to a release of histamine and several other chemicals into the bloodstream, and these chemicals will cause some harmful effects. I want you to think of it kind of like this. Once the antibody and the body identifies that the antibody is there, it almost starts dispatching things like get rid of, do whatever you can to destroy this and get it away. So histamine could be thought of more like an acid, and the body starts to secrete mucus because mucus will help wash away these substances that may be in the body. So we'll take, for example, your allergic rhinitis in your nose. Anybody who has that seasonal allergy, well, your nose starts to run a lot, partly because the body's trying to find a way to flush that substance from the system. And so by having lots of moisture there that eventually runs out, hopefully it will wash that. Well, the same sorts of things happen in patients with allergic reactions in other parts of their bodies as well. So people who are having an anaphylactic reaction often have shortness of breath. Well, some of that shortness of breath can be from swelling of the tissue as well as the histamine and mucus release that is trying to wash some of those substances out of the body. So effects of histamine and the other chemical mediators, obviously inflammation is big. With inflammation comes also bronchoconstriction. We also get vasodilation, which is maybe not something a lot of people considered, but that's why you get the red skin, the very splotchy skin, is some localized vasodilation in certain areas. That vasodilation can be a big deal when we're talking about a systemic reaction, a systemic vasodilation, where you get all of the blood vessels in the body vasodilating at the same time. I believe I've mentioned in the past that if all of the blood vessels in your body dilated at once, you would pass out because you don't have nearly enough blood to fill all of those. So with massive vasodilation, the patient becomes shocky and they don't have the blood to fill their system, and many times will start to get hypotensive. They may start to be tachycardic and pass out or have syncopal episodes. The bronchoconstriction and the inflammation, they go kind of hand in hand, as well as the release of mucus. So anaphylaxis is a severe life-threatening allergic reaction. It can cause dilation of the blood vessels, can cause airway swelling, and cause bronchoconstriction or respiratory failure. So if you shrink the bronchioles, you cause some swelling on the inside, so it not only caused the constriction of the muscles, but now the tissue got thicker, so that shrinks things down even more. And then you throw some mucus in there on top of it, you've really narrowed any of those air passageways. We've got that severe dilation of the blood vessels. So some of our more common allergens that we see: insects, food, plant, medication, other things such as dust, makeup, soap. There are all kinds of things. There are some oddball autoimmune disorders that will look like allergens, where people they'll say that I'm allergic to my own hair, and in a sense they are. It's the body trying to react to the substance that it, for some reason, has decided it doesn't like. So when we talk insects, most of the time insects are the flying, stinging insects, which belong in the family Hymenoptera. That's the wasps, the bees, the yellow jackets, hornets, so on and so forth. Bees are usually the most common offender when it comes to insects. Foods, some more common food allergies: milk, and you can actually have a milk allergy that is beyond being lactose intolerant. to a degree, all humans are slightly lactose intolerant. We're not intended to digest the proteins of many of the commercial milks available, but people can have severe allergies to milk. Nuts, for sure, are huge, and then certain seafood, mostly the shellfish, so the lobsters and the crabs and so on and so forth, that you'll hear people talking about. Occasionally things such as tomatoes, strawberries, chocolate, which has got to be one of the worst ever allergies to have, but those are certainly heard on a fairly regular basis. Eggs is another one. Plants, certain plants that people will have allergic reactions to, and this is a bit different than your standard poisonous plants that you come into contact with, like poison oak, or poison ivy, poison sumac, stinging nettles. They will have certain plants that if they come into contact with some of their saps, that they have the same allergic reaction. Medications are very big. There are kind of a handful of medications that we see on a real regular basis. Aspirin, penicillin, and sulfa are probably the top 3 medications for people to be allergic to. Additionally, you have people that are allergic to certain types of opioid narcotic agents, so morphine, codeine, Dilaudid, fentanyl. There are some people who are allergic to other diagnostic things such as IV dye. Sometimes when they'll do a certain type of radiologic test, they inject some dye into you, and when they do that, it actually causes you to have an allergic reaction. And then the others. Okay, so dust is huge. It makes, most of us react poorly to that. Latex, I mentioned latex and bananas kind of having a connection in there. So those are a few things that you will hear people commonly be allergic to. Remember that sometimes people say they're allergic to things and they're actually not allergic to things. So if you ask somebody, do you have any allergens? And they say, yes, I'm allergic to this, that, and the other thing, then it's also a good idea for you to ask, okay, well, tell me what it does to you. So, well, it causes me to get itchy. It's different than it causes my airway to swell up and I have a difficult time breathing and my eyes swell shut. Obviously, the latter is an impressive allergy, whereas you get some people who are, oh yeah, I'm allergic to morphine. And why are you allergic to morphine? What does it do to you? Well, it makes me feel goofy. Well, it makes everybody feel goofy. That's part of what it's supposed to do. So sometimes people confuse side effect with allergy, where an allergy, it's, now we know some of those specific signs. All right, so latex allergy, I mentioned this, common concern for EMS. There are a lot of patients developing latex sensitivities. Another one that people are relating to latex sensitivities are people with peanut allergies, also complaining of having or coming down with latex sensitivities. So providers need to be concerned with this, and there are even providers that are developing latex allergies due to long, prolonged exposures. We've gotten a lot better in EMS in removing as much latex as possible from our trucks and from our bags, but there's still a number of things that cause people to have problems with some of our equipment. Perhaps a good question to ask is ask a person about their underwear. And when I say that, that sounds goofy, but if most people can wear standard store-bought Fruit of the Looms or Hanes Herways or whatever, most of those have latex in the waistbands. So if they can handle that, in most cases they'll do okay. If they can't, if they have issues from the latex in their undergarments, then that's something we should definitely be concerned with, because we have a lot of things that have latex. A lot of our oxygen stuff has gone away from it. It's become different plastics, but some services are still wearing latex gloves. We still have latex in many of our blood pressure cuffs, perhaps some of our stethoscopes. So latex is definitely something to keep in mind. So the course of a reaction, There's no way to predict the exact course of an allergic reaction. Severe reactions often take place immediately, but they can even be delayed for more than 30 minutes, whereas mild allergic reactions can progress very rapidly into anaphylaxis. Generally, you don't get better in the continuum of your history of your allergies. You don't usually go, oh, well, yeah, I had a big anaphylactic reaction last time. 3 times ago it was anaphylactic. Last time it was, just a little bit of itching. So I don't think I'll even have an issue now. That's really not very common. Most of the time it gets worse each time you have a subsequent reaction. So it's something you got to be very concerned with. If you're talking to patients and they're like, yeah, last time I had an allergic reaction, they had to put me on a ventilator. That should scare you. That should make you nervous that this has the potential to go south real quickly. So our signs and symptoms that go along with this: swelling and flushed skin, and this is an example obviously of flushed skin here. Also see some swelling in the eyes there, and perhaps a little bit in the face as well. A warm, tingly feeling in their face, mouth, chest, hands, or feet. And that can be from all this blood flow from this peripheral vasodilation that's going on. So all of that kind of comes from that. The swelling really is from a lot of the histamine release and the mucus release that goes with it. We also have hives. This is an example of kind of the finer, smaller set of hives, but they're just little raised bumps. And those little raised bumps can be bigger than that, can be significantly bigger than that. But that's another reaction then from the histamine release as well as vasodilation. We can have a number of respiratory signs and symptoms go along with it. Tightness in the throat or the chest, cough. It's not usually a productive cough. Rapid, labored, or noisy breathing. And when we're involving respiratory, remember that this has the potential to go bad quickly. A hoarse, muffled voice or loss of their voice as things start to swell down. Remember, swelling on the outside gets puffier, so our hand becomes twice the size as it was before. Swelling on the inside a lot of times means it's actually may not be getting quite as big around as you might think, but it's swelling on the inside as well, so it's pushing inward. Stridor and wheezing. Oftentimes patients with allergic reactions will have wheezing, and they can progress right on into stridor or high-pitched crowing. So cardiac signs or symptoms, we have an increase in heart rate and decrease in blood pressure. Because those vessels have dilated so much, the blood pressure starts to drop, and the heart, in an attempt to compensate for that, kicks up its rate. So when it increases the heart rate, it's in an attempt to fill the system and beat a little faster to try to keep up with the demand. Other generalized signs or symptoms: itchy, watery eyes and/or runny nose. That there in itself often describes many of the minor allergic reactions. We may not even start to see much of the other stuff for some time. Headaches, a feeling of impending doom. This is another situation in which if you've got a person you think's having an allergic reaction, they say, I think I'm going to die, you should probably believe them because they may be not far off. Altered mental status. Again, altered mental status pops up. This pops up in lots and lots and lots of our medical emergencies, but the reason that altered mental status again occurs is because they're short on O2. They need more oxygen in the system, and without it, they start to lose their edge. Flushed, dry skin can be pale, can be cool, can be clammy. In most cases, it's fairly flushed early, and then as they get more and more shocky, then they become more pale. Nausea and or vomiting, and then changes in vital signs. Again, remember, blood pressure goes down and heart rate and respirators typically go up. So signs or symptoms of just a generalized reaction: the itchy, watery eyes, the headache, the feeling of it. I think I backed up. Sorry about that. distinguishing anaphylaxis from a mild allergic reaction. Any of the previous signs and or symptoms can be associated with an allergic reaction. Anaphylaxis has respiratory involvement and or shock. So respiratory involvement and or shock. That's when you have an anaphylaxis. That's when you have a life-threatening emergency. A lot of people, when they have their minor allergies, develop a little bit of a rash. Both of my children have an allergy to penicillin, and after they had been on a penicillin-based drug, they were on about a 10-day course of penicillin-based drug each time, and it wasn't until about day 7, 8, or 9 that we even started to see anything pop up. In fact, they kind of got this rash right at the end of their first time. We didn't think much of it at the time, and then after the second time they went on that drug, within a couple of days we started to see that rash pop back up, and we were able to go, oh, now wait a minute, that's related exactly to the drug. So sometimes this progresses very slowly. So our assessment, primary assessment, we remain vigilant on ABCs, and remember, airway can quickly go away. We can quickly lose an airway. Breathing can quickly become very labored, and they can get to the point in which they're exhausted. Of course, circulation is going to be affected as well. History and physical exam. So any history of allergies, that can be very key. Now, sometimes they have this history of allergies, but they don't know that they've actually had any exposure. And so that can make it difficult to pinpoint what's going on here. But if they've had this history of allergies and they know how they've reacted before and how they're reacting now, usually we can say, yeah, this is an allergic reaction, but to what? So what was the patient exposed to? Did they know how they got exposed to it? Sometimes people are just stupid. They're like, well, yeah, I'm allergic to many nuts, but I ate this candy bar. Knowing, oh yeah, I'm allergic to nuts. Sometimes people have accidental exposures. You're starting to see a lot of product packaging listing certain things that may have been in the facility where this product was made, and most commonly you see may have been this product was made in a facility that has peanuts and tree nuts. So look at their signs and symptoms. Do they make sense? Do we determine whether or not they have a life-threatening event going on, or is this really more of a minor event, a generalized event? So we're looking for all those. Is there shortness of breath? Is there difficulty breathing? Is there respiratory sounds? Is there hypotension? Is there tachycardia? Or do we just see some of the flushing, maybe the hives, maybe a little runny nose and itchy, watery eyes? How does it progressing? If they call us and say, I've got this rash and runny nose and headache, and I feel a little anxious, but it's been this way for 4 days, hasn't gotten any worse, that's all right, that's good. They said, well, 20 minutes ago I started out just having a little bit of a feeling itchy and watery eyes, but at this point now I can't breathe. Obviously that's moving quickly. So any interventions that the patient may have done as well. What have you done? Many patients who have allergies probably also have an inhaler, and if they have this inhaler, they may have taken their inhaler. Ask them if they've taken their Epinephrine Auto-Injector if they have one, or their EpiPen. Most people will call it EpiPen, although that's a brand name. So if they have taken it, when did you just take it? Did you have it 5 minutes ago? If they had it 5 minutes ago, we've got about another 5 minutes before we're going to give another one. If they took it right before we walked in the door, 30 seconds ago, we should probably hold off and let it take some effect. So treatment is obviously going to be supportive of the vital functions, so airway and breathing. High flow O2 in many cases, provide artificial ventilations if we can. Occasionally we'll have difficulties maintaining a decent airway here, and so it's going to require us to be looking at ALS. You should always, if you have an anaphylaxis, ALS is a must. They're going to probably need to place some sort of an airway, not to mention they have a variety of drugs that they can use on this patient. And then consider assisting the patient with their Auto-Injector. If the patient is not wheezing or not showing signs of shock, do not routinely give the Auto-Injector. Talk to medical control, explain the entire situation, and continue your assessment. Their blood pressure is fine, their heart rate maybe is just a little elevated, and they're anxious but really not struggling to breathe. Think that this is generalized, but if you have a doubt, talk to medical control. Epinephrine is not without certain side effects. It's very difficult. It's very hard on the body. It's an ugly drug, and it can really really push your heart to the limit. So when to use an auto-injector? Number one, the patient's come into contact with a substance that's caused an allergic reaction in the past. If the patient also has respiratory distress or exhibits signs or symptoms of shock. In most places, use of an Auto-Injector is a patient-assisted medication, so it's going to require that patient to have that drug, have it on them, or easily accessible, and then obviously there's an order for that patient to use that, so that's prescribed to them. Most places are not carrying Auto-Injectors on the trucks. A lot of that depends on state rule and regulation. So if we're going, after we administer an Auto-Injector, we've got to remember to record the administration, transport the patient, and reassess. It's kind of silly that that's not placed there, but transport the patient is very, very critical here. Auto-Injector is going to last you all of about 10 minutes, so that's why we've got to be concerned with that. If you look at 537 in your textbook, it kind of talks about the process of doing the Auto-Injector. Make sure that it is the patient's, make sure that it is not expired, and then there's usually a clear window somewhere on that. You want to look at that to see if it's become cloudy or discolored. Maybe there's no liquid left in it. If you're given the approval to give the Auto-Injector, then you're going to need to know how to use it. The ones that they're showing in the textbook, there's a couple of them there. They have the older style EpiPen, which is it looks like a magic marker. There's a gray cap and a black tip. The black tip is the business end of that. The gray cap they pulled off on 537, picture number 5. They pulled the safety off of there. That little cap, when it's installed in the device, it keeps it from firing. There is a spring-loaded needle in there that comes out the black end. So if you would like to have a spring-loaded needle fire into your thumb, by all means, put your thumb over the end of it. If you look at the next page, 538, picture number 8, they have a picture of what's called a Twinject. That Twinject, you can help them with the first dose of that because the Twinject has a Auto-Injector dose, and then you disassemble it, and there's another backup syringe worth of epinephrine in there. However, it is not within your scope to give it via syringe. So if you look at 540, 541, 540 has a nice big scan over the drug epinephrine, talks about its administration. 541 has some pictures of both the older style EpiPen and then the Twinject. I would encourage you guys to do a quick web search for EpiPen or Auto-Injector. They recently have come out with a newer version of the EpiPen, and the new EpiPen is it looks a little different. It's more oblong shaped as opposed to round, and it has a blue cap and a orange cap, or tip, I should say. Blue cap, orange tip. So the blue cap, they say point the blue towards the sky, which makes a little sense, and then arm it. And then the orange end of that says warning, because that's where the needle is going to fire out of. The needle does not retract on all of these devices. It does not always retract into the device. So you very well could end up with a bare, sharp needle that's been in a patient. So you have to be very careful with that. So the way you're going to administer your EpiPen, though, is after you've gotten approval, after you've done the assessment, you're going to take that EpiPen out. You're going to undo the safety, which on the pictures they show you in the textbook most of the time is the gray cap. You pull that gray cap off. You've assessed your EpiPen to make sure it's all good to go. And then just like they show on the picture on 540, you put that on the outer thigh. You put the black tip up against the outer thigh, or the orange tip on the newer one, up against that outer thigh, and then you firmly push it against their leg. That black cap or the orange tip, or black tip or the orange tip on the newer one, or the green tip actually on the Twinject, kind of gives a bit. And with that give, that's what causes the needle to fire. And it'll fire the needle in there. You need to count to 10. Count slowly to 10 before you even move that, because it takes a couple of seconds for them to inject the medication fully. And is injecting that medication either into their muscle or their fat tissue, depending on that patient's body structure. Now, epinephrine is good for about 10 minutes. So if you haven't done anything with this patient within about 10 minutes time, they are going to start heading south again. So reassessment can show that that patient's going to start to deteriorate. You may need an additional dose of epi. You're probably going to need to talk to medical control. You may have a protocol that says it's okay. And it may require you to have the patient's additional auto-injectors. If no auto-injector is available, and I'd request an ALS intercept and treat them for shock. Hopefully, you should always be calling for an ALS intercept if you have an anaphylaxis, regardless of if the auto-injector is available or not. The paramedics carry epinephrine that they can give via syringe. They also carry steroids, some breathing treatments, some Benadryl that are going to help combat a lot of these issues with the allergic reaction. So to think about a bit, should you administer an auto-injector for a simple allergic reaction? The answer to that is no. Again, if they don't have respiratory involvement or don't appear shocky, the risks of giving this drug far outweigh the benefit. Giving them epinephrine for this very mild allergic reaction can actually cause them to have a heart attack because it's too strong. This person needs probably some oral Benadryl, and hopefully they've been doing that at home. But if you don't have respiratory involvement or shock, do not give epinephrine, unless medical control tells you otherwise. What assessment findings would indicate the need for epinephrine? I've said it, but it's respiratory involvement and or shock. And when I say respiratory involvement, they are truly struggling. So there's a video on anaphylaxis and then on allergic rhinitis or hay fever. So real briefly on self-administered epinephrine again. Commonly prescribed to patients with a history of an allergy. They have these auto-injectors for people to carry with them. Usually they're issued several of them. They may have them in their car, they may have them in their purse, they may have them around the house. There are some problems though with this. So oftentimes they get thrown in the car and left in the car, and here in Nebraska and Iowa in the summer inside the car it gets to be 130 degrees. It starts to take its toll and break down that drug. It is a naturally occurring hormone created in the body. Epinephrine is what we commonly call adrenaline. When you get an adrenaline rush, it's actually epinephrine. It causes a constriction of blood vessels and it dilates bronchioles, which is the opposite of what we heard anaphylaxis does. So if anaphylaxis dilates blood vessels and constricts bronchioles, we give this to kind of counterbalance. Side effects of epinephrine: increased heart rate and an increased cardiac workload. It is very hard on the heart. It's actually kind of a nasty drug. The auto-injector, again, spring-loaded needle with a syringe. Upon administration, that medication automatically releases as it injects. You need to remember, again, hold for a count of 10. Once you inject, particularly this older style, I said the needle may be exposed. Most of the time these come in a little protective sleeve or tube, and that protective sleeve or tube often has a built-in sharps container that you can use. It has a little rubber pad in the bottom. If you drop the EpiPen back into it, it will ditch that needle for you. So we typically will inject anterior medial thigh, so midway between the waist and the knee, and you can go on the inside of the thigh, or actually the outside of the thigh is fine. If you can, remove the clothing from the site. Just helps keep us from injecting anything that might be on the surface of the pants, or the skirt, I guess. Try to clean that up and keep it as sterile as possible. Use your standard precautions, of course. Remove the cap. Press the tip of the auto-injector, black or orange, depending on what type, or green, firmly against the patient's thigh. And once that needle is deployed, allow a full injection of the medication. So for a count of 10, a slow count of 10, and then carefully discard. You will have that exposed sharps. There are typically two sizes of auto-injectors. There's the adult and there's the ped version. Adults give 0.3 milligrams of epinephrine, and children will give 0.15, which is half the dose. This is typically for children less than 66 pounds, or roughly 30 kilos. If you look on 541 again in the text, the yellow EpiPen is the adult one. The green EpiPen is the child version. So in review, allergic reactions fairly common, anaphylaxis fairly uncommon, but it is a true life-threatening emergency. It's a major allergic reaction. Most common sign or symptom to go along with the allergic reactions is itching. Patients with anaphylaxis will also have the life-threatening difficulty breathing and or signs of symptoms of shock. So we've said that about 19 times now. Patients with anaphylaxis will be extremely anxious. Patients with minor allergic reactions might be slightly. Their bodies are in trouble, and they're finding out very quickly that they're in trouble. Those signs or symptoms of anaphylaxis result in some physiologic changes such as vasodilation, bronchoconstriction, leaky capillaries, thick mucus. And by quickly recognizing the condition and consulting medical direction, or if you have a protocol, which maybe allows you to do this, you can administer that appropriate treatment. Remember, oxygen is first, then think about the other drugs. If you need to be breathing for this patient, breathe for the patient. In allergic reaction, the body's immune system overreacts and has some potentially ugly side effects. And then anaphylaxis is this really severe systemic form of an allergic reaction. Anybody who has a problem with cheap metals, say nickel, or maybe it's you can't wear certain types of jewelry because it causes you to break out. That really is a type of a reaction, a type of allergic reaction, but it's localized. It's not a systemic problem like anaphylaxis. All right, so EMTs must use assessment to differentiate a localized allergic versus a systemic anaphylactic. Epi is useful in anaphylaxis because it counteracts the blood vessel and respiratory issues. So it dilates those constricted blood vessels. It dilates the constricted bronchioles, and it helps to constrict the dilated blood vessels. It does have potentially serious side effects and needs to be only used in cases of anaphylaxis. So it's almost like you've had one or too many Red Bulls or cups of coffee or what have you. Well, this time's about 10. So, what are the indications for administration of an epi auto-injector? Obviously, a suspected or known exposure, signs or symptoms of an allergic reaction that include either respiratory depression or respiratory failure and or shock. Some of the signs, some of the more common causes of allergic reactions: foods including nuts and shellfish, certain berries, milk, chocolate, medications such as aspirin, morphine, penicillin, sulfa, plants, and insect stings. So list the signs or symptoms of an anaphylactic reaction associated with each of the following. So skin becomes flushed, and eventually pale. You may have some urticaria, which is the medical term for hives, urticaria. Respiratory system includes difficulty breathing, wheezing, stridor, coughing. Cardiovascular, tachycardia, hypotension. Your critical thinking question. 24-year-old male ate a meal that he believed contained shellfish. He is allergic to shrimp. He's sweating and nervous. He appears to be breathing adequately. You do not note any wheezing or stridor. His face is slightly red. His pulse is 88, strong and regular. His respirators are 24. Blood pressure is 108/74. His skin is warm and moist. Should you administer epinephrine? The answer to this is probably not. You can discuss it with medical control and see if they want you to do that. But in most cases, I believe they're going to say no. He doesn't show signs or symptoms of shock. Look at his pulse is normal, and his blood pressure are normal. His respirators are fine. He does have a little bit of an increase in respiratory rate, but he, other than that, doesn't show a lot of signs of having major respiratory issues. That's not to say you shouldn't have it out and ready to go should you need to give it. But at this point in the ball game, probably not. It still wouldn't be maybe a bad idea to discuss having the paramedics come out here with you guys. But in most cases, I would say no to the epi here.